Good morning, everybody. I would like to speak with you about asphericity, spherical aberration, presbyopia, and the links between them and presbyopic treatment with irregular laser from alcohol. I have no financial interest with the company. No. This one. Okay. Thank you. You know that presbyopia is a decreasing accommodation. It's symptomatic at about 40-45 years old, and it's earlier if hyperopia existing with no correction. Yes. So presbyopia treatment is a considerable market. So its technique must be easy and safe. You know that cornea have an aspherical surface. It curves vary from center to limbus. You have the flesh? Yeah. So for a product shape, the central ray light have converge in a point, and marginal ray light converge in another point. This difference defines the spherical aberration. For a product shape, the spherical aberration is positive. For oblate shape, it is positive too. And if you have a hyperprolat shape, you have a spherical aberration, negative. This is for cornea. And the lens with accommodation have variable asphericity. You, me, we have maybe all prolat asphericity. 80% of persons have a prolat asphericity. The mean is minus 0.26, 27 or 25, it's almost the same. And the spherical aberration, Z4, is plus 0.25. Only for cornea. With Patacam, we can have Zenke polynomial results, and you can choose only spherical aberration. You can choose here, and this an example of corneal spherical aberration positive for a patient with hyperopia and no corneal surgery before. Yeah. So, normal cornea, you have spherical aberration slightly positive. The lens move, so you have spherical aberration slightly negative. And during accommodation, the change of lens curvature increase the negative spherical aberration. With presbyopia, the rigidification of lens linked to increased positive spherical aberration of lens of the wall A. Sorry. If it works, maybe, yeah. So, like we can change the evolution of lens today, we want to change the shape of the cornea to obtain a negative spherical aberration of the cornea to compensate the progression of the increasing of the positive spherical aberration of the lens. Two status, hyperopic patient and myopic patient. I avoid to program surgery for hemetropic patient. So for hyperopic patient, the Q target is minus 0.8 with optical zone of 6 mm. You will see another presentation in some minutes. We can give some slightly different program protocol that we can discuss. An example, it's an ophthalmologist patient. 5 years ago, you have upside the reflection. It's an hyperopic patient. The Patacam topography map. This given by OCAS device. It's a program who can give you the residual accommodation, and you have one diopters or 0.75 diopters of residual accommodation for the patient. The program of surgery. Postoperative 2 years. Refraction, asphericity of the cornea, On the right one, we have the dominant A, and left A, non-dominant A. And you can see residual accommodation of the both eyes. So you have a very good, without correction, visual acuity. 4 years after surgery, the reflection is stable, asphericity, and residual accommodation. It was 1 year ago. When you study the Zanicke polynomial with Pentacan, with the right one, you have a spherical aberration slightly negative, and in the left one, slightly much negative. So this spherical aberration compensates the loss of accommodation of lens. Which information for patient? At the beginning, for hyperopic patient, you have a myopic shift for few weeks or maybe few months. So you have to prevent them about the far vision blurring. You have eyes tired, so you have to prevent them about orthoptic treatment. It's very important to be there after surgery to manage them. They need light to read, because the light increase meiosis and help to converge. And of course, dry eye, especially for women after 50 years old. For myopic patients, it's almost the same. Just asphericity is a pure target. It's -1. Because myopic treatment give an oblate shape, but we want increase the prolate shape. So you have to program more asphericity. Of course, you have to inform your patient about light read, about dry eye, the same. How does it work? In modifying corneal spacity, so residual lens accommodation become usefully. You can increase the depth of focus. And for hyperopic patient, at the beginning, you have a micromonovision at the level of Z4, and it is regressive with time, in 1 year. And like Damien Gatinel said, the variation of spherical aberration modify defocus when pupil size decrease in accommodation convergent reflex. So, in conclusion, technique is easy, reproductive, safe, reparable. We can manage another treatment with aspheric treatment. If you have regression with time, we can it one more time. And for this patient, we can use in cataract surgery, we can use bifocal or trifocal IOL in cataract surgery. The most important is binocular vision and explanation. We have to be there. It costs much more time, in fact. Thank you very much.